So Nunkari Nungi, everyone. Nanawai Paul Worley. Welcome to this year's race grand round, an opportunity for the Academy to learn from the best of the world, to interact. And we have someone who has their microphone on, so I'll just ask them to turn the microphone off. But welcome everyone. We have a real gem to start the year this year. A Flinders graduate, Dr. David Mills, who is speaking to us from Hagen, Mount Hagen in the Central Highlands of Papua New Guinea. But he's speaking to us about work that is more remote than Mount Hagen in Inga province in Kompian, a place that I've had the privilege of visiting David, and a number of our doctors here have actually worked with him when he's worked in the Riverland and the southeast of South Australia. And of course, many of you would also know that he was recently honoured with a Medal of the Order of Australia in the Australia Day Honours, and congratulations to him, very well deserved for his work in medical education in Papua New Guinea in particular. So an opportunity to learn of what a South Australian is doing with people in Papua New Guinea around medical training, and potentially an opportunity for us to collaborate further in the future. Welcome, David. I'm really looking forward to what you have to say.
Thanks, Paul. Well, thanks for the opportunity to speak. I'm conscious of the fact that you guys don't have a lot of time, so I'll try and fly through this and hopefully save a little bit of time at the end for questions. So my agenda, I suppose, is just to give you a little bit of a background to Papua New Guinea and some of the challenges there. It's such an interesting country because many people don't know that it was part of Australia until fairly recently. It was a territory until 1975. Of course, it's our closest neighbour. It's only an hour's flight from Cairns. And 11 million people now, but just it does really feel like a different planet, I have to say, switching between the two countries as I do now in my work. So just want to give you a little bit of briefing, I suppose, about the nature of the country and the challenges there, and then something of the environment, medical environment, and then the training of doctors, what that looks like in PNG, and then just hopefully close it out with just a few, I suppose, lessons learned. And I'm not sure, to be honest, on the applicability that you will feel about them, but perhaps we can discuss that at the end. So there's the map. PNG is a country of 800 languages, incredibly diverse. The highlands run through the centre, as you can see there, and then the coast and the islands really make for just such an incredibly diverse community. One of the things that people don't realise about PNG is just how recent the contact with the outside world has been, particularly in the highlands. This photo is taken from the mid-1930s, which really was when the very first contact happened between the highlanders of PNG, where I live, and these guys were gold miners. The point of this slide is I mean, this guy's just basically using his firearm and one of the local pigs to demonstrate that the nature of the weapons, and basically sending a message to just leave us alone. I'm not going to delve into the sort of rights or wrongs of that. The point of the slide is really to ram home the point that in PNG, the nature of the exposure to the outside world is really, really recent. So where I live and work, really it's the 1950s and 1960s that the people had, really the first contact. So, you're really watching a culture evolve in rapid time. And keep in mind that independence was, for many of these people, only, a handful of years, 10 years after the first contact. So it's an extraordinary story, and, all sorts of cultural sort of observations, I suppose, to be made out of that, but that would be for another talk. The arrow shows where I live and work with my wife and our kids. I sort of split my time. We were there full time for 23 years, but now I live and work in Narracourt and split my time between there and PNG in my ongoing work there. That's what it looks like. So this is the sort of centre of the district where we live. And, you know, I suppose the first thing that strikes you perhaps is just how small that centre is. This would be the equivalent of like the regional centre. So for the southeast of South Australia, you know, maybe Mount Gambier perhaps would be considered the regional centre. But in Compiègne, where I come from, it's just a tiny dot. And that's because the majority of the people are sort of spread out through the mountains. And so you don't have these concentrated populations. People are spread out over huge distances, and part of the logistical challenge of that I'll be speaking about. When we first went there in 1999, this is what greeted us. This is what, you know, was the equivalent of the district, what is the district hospital at that time. So it was just two buildings. We had one staff house. There was no laboratory. There was no X-ray. There was a small room with a single light bulb that was our operating theatre, and we had a little generator that ran for 3 hours a day. So that was the hospital for a population of 50, 60,000 people. So it's pretty basic, and that scenario is fairly typical around PNG. Particularly in the highlands, people still live very traditionally. They're subsistence farmers. If you're on the coast, it would be fishing. But people, for the most part, live off of what they can, you know, find from their own endeavours. There may be some cash cropping, coffee, peanuts, things like that. But for the most part, people live out of the forest the best they can. That's a traditional house you can see there. That's fairly normal where I live. And the infrastructure is pretty tough. So this is basically the main highway into the district centre, or it was. It's slightly better than that now, but not a great deal better. So just the logistical challenges of getting materials, food, diesel, you know, in and out of a hospital really are huge challenges in PNG. This is our ambulance service. For the most part, if you get sick in the highlands of PNG, you're going to need relatives to carry you quite long distances. They've made that stretcher out of some bamboo, and they'll have a team of people that will carry you sometimes for a day, sometimes 2 days, to get to some kind of a centre. I'm not going to go into the full story of this, but what you're looking at here represents kind of the lucky minority that actually do make it to a hospital there. One of the huge, you know, head bending, I suppose, facts about PNG is just an enormous amount of morbidity and suffering goes without any care or any redress whatsoever. And I have to say that as a Westerner, it took me ages to get my head around that people would just have no options whatsoever. If you're on the coast, it looks like this. You try and find someone who's got a dinghy and put them in the boat, and away you go. I was recently doing a visit to one of our training doctors on a fairly remote island. We had a guy with a strangulated hernia who needed to be moved. We had to put him in a dinghy just like this, and it was about 6 hours in the dinghy to get to the capital. Some of the centres I visited, 14 hours on the open ocean in a dinghy to get people from one place to another. So really huge sort of challenges for people to get any kind of service. And then that's, of course, if you've got access to, you know, to those sorts of things. For a lot of people, it just requires walking. You've just got to walk. And of course, that works in reverse. So if you're then trying to do primary healthcare interventions like vaccination or education, you've got to walk yourself. So this, on the bottom of the screen there, you can see this is a vaccination patrol. We hire some carriers, and they'll carry some stuff for us. The Eski's got the vaccines in it. And, you know, some of our staff will be out for several days, you know, walking distance just to reach small communities to do that. This is one of the things we make our medical students do. For many of them, they've never done any hiking before, and it's one of the first things we do. In fact, I've only just last week taken another group up to the highlands. It's one of the first things we did was start to get them out walking, because that's the reality of providing healthcare, and they've got to sort of, as the future leaders of the system, they're the ones who have to kind of know about it. So the disease profile look very heavily toward the infectious end of the spectrum. I have to say that it is changing. You do have people who live in the cities, and it's still a fairly small percentage, probably 15 to 20% of people now live in cities. And if you have access to money, then you do start to see the emergence of non-communicable diseases, diabetes, syndrome X, ischemic heart disease, that kind of thing. But for the most part, the big disease burden in the rural parts of PNG is infectious. So this child's got cerebral malaria, meningitis, this is tuberculosis of the gut. These are all very, very common, and HIV as well is also very common. And particularly, sadly, in the highlands, trauma, lots and lots of trauma, machete-based trauma for the most part, and complicated. I mean, you can see just this is a fairly standard example. This is not from the sort of gross folder of the photos. We would be getting something like this fairly frequently. So complicated fracture, tendons, nerves involved, really difficult case. Those sorts of things front up fairly often. So one of the things I kind of haven't mentioned here is about the spread of the population. So, I mean, Paul will probably correct me on this, but let's say in Australia that the split between cities and rural, regional, maybe, I don't know, Paul, maybe is it 20%, 25% rural, regional in Australia now? In PNG, it's almost the inverse of that. So we're looking at 85% of people living in these rural and really remote areas. And so 11 million people, you can do the math on that. This is a map of PNG broken down into its districts. It's about 8-9 years old now. I'll show you the current map in a minute, but you can get a sense of this. I mean, each one of those districts is about 120,000 people. And you can see there that we're looking at more than 50% of the country with not any doctor of any kind in attendance. So we're not talking about specialist doctors, obstetric doctors, or general practitioners, just any kind of doctor, none whatsoever. So it's a huge deficit in medical personnel. Obviously, all countries complain of this, and I'm not trying to say that PNG is the only country, but these are pretty big numbers. We're talking about millions of people that have no doctor anywhere in their local vicinity. And when you have a country that's so heavily skewed to the rural, that's a massive issue. Again, I'm just going to skim through this, but basically we've been working on this problem for many years now, and our plan has sort of had this fourfold prong to it, and the four pillars, I suppose, the four beams of the bridge, if you like that analogy, were to, first of all, we realised we needed to expose the students to rural communities and actually make them aware as to what rural PNG was, because PNG is a country that only produces 50 medical students a year for 11 million people. So you can imagine those kind of numbers. The people who do actually get access to medical school usually come from the elite families. They're from the capitals, and many of them have no idea about the rural populations at all. And so it's a huge shock to them when they actually do get out bush. So exposing students, then we had to create a training pathway. Obviously, Australia's had training pathways, good training pathways now for general practitioners for many years. PNG had no training program at all for general practitioners or rural general practitioners until fairly recently. So that's something we had to create. And then we had to find a way to support those doctors who were willing to go in the field. And lastly, and certainly not least, this is probably one of the huge parts of what we do is really advocate, convince the system that things needed to change. Which is happening, but certainly is taking a great deal of effort. So I'll just sort of run through these very quickly. So exposing medical students looks like this, getting them out bush and actually meeting the people. And as I said, that means walking, means traversing rivers, it means going up and down mountains, getting them in the dinghies and actually finding out what it looks like to live in these places and what the needs of the people are. Getting them introduced to district hospitals. For many of them, they don't know any other hospital apart from the hospital in the capital, and they don't know that there are any hospitals that actually work. So for them to find good district hospitals, practice their clinical skills in rural environments, much as you guys have done at Berry, is a big eye-opener for them, and really quite a revelation. They get to practice all sorts of skills. This week in Compium, we're teaching our students how to take x-rays, to do cross-matching of blood, and all sorts of things that they've never done before. So, but then we also, one of the big mantras we have for our doctors is you've got to get dirty. You can imagine if you are one of the really, few doctors in the country, that you do have an elite position in the community, and human nature being what it is, sometimes if you're part of an elite, you leave the dirty work to others. But we really make it a big deal to make sure that our doctors do get dirty. So this is teaching medical students how to dig pit latrines, which is, a really important thing for us to be teaching in rural PNG. And they sleep with the people out bush, so they understand, for example, what is the role of housing in people's health, which is a massive, massive thing that we just take for granted in the West nowadays. But so much of public health advancement in history has actually been about improving the quality of people's housing, ventilation, sunlight, all of these sorts of things have been so crucial. They really learn that by experience when they're out bush. And they get to, practice their clinical skills, do what they can in a really rural or remote environment. So then the second thing was we had to create a training pathway so that if we did get doctors that wanted to go and do this, we knew from experience that some of them had tried it, but they were just terrified. It was just so daunting, the amount of things that they had to do. So we created a training program, a specialist training program, which goes for 6 years. Most specialist programs in PNG go for 4 years. This one is a little bit longer. They have to do a whole lot more. They do surgery, they learn anaesthetics, but they also do some strange stuff like having to learn how to fix a vaccine fridge when it breaks down, how to install a radio antenna, stuff like that. How to cross-match blood. If you set up in a district hospital, very often there won't be a lab person there, as there wasn't in my case in Compium. So you might actually have to know how to cross-match blood for yourself, because that's a crucial part of the surgical work you're going to do. And through that process, they do a series of exams. After 3 years, they do their part ones, and at the end of the 6 years, they do part two. You'll no doubt recognise Ken Wangahu, who's our external examiner. I have to say, I'm not sure we could have chosen a better external examiner than Ken. Not obviously he's well known in your circles and in RACGP, but also his experience in South Africa and Kenya just made him have a level of insight to the challenges these guys were facing, which was really incredibly important to us. So we're very grateful to have him. And at the end of it, they graduate as specialists in rural medicine, which has been a huge plus, I have to say, to the sort of medical milieu of our country. Just quickly moving on, I think I won't touch on this for very long, but basically, one of the huge challenges we faced was, well, what sort of training do we give these guys, and what do we model it on? And I think probably, the best model in my mind anyway has just been that of kind of a wartime situation. The thing that strikes me about war is that for all of the awful things that come out of it, there's a huge amount of flexibility and thinking on the run and creativity. People have to sort of solve problems in a hurry. So wars are not protocol driven, and certainly medicine goes through all manner of innovations in wartime settings. And really PNG is very much like that. We've had to really learn to think on our feet, do things differently. You've got to use the right tools. So, for example, probably our main surgical textbook is one that you guys may have not heard of. It's one called Primary Surgery, and it's written by people who lived and worked in Africa and India. And it has these very strange illustrations in it, like this one, for example, or this one, where, you'll never see that in Bailey and Love or a standard sort of class, surgical anatomy or something like that. These are, scenarios that Papua New Guinea doctors understand quite well. And I think the one on the left is incredibly important to speak to here, because for most of these doctors, they have no options to refer patients, and that completely changes the paradigm of how you work as a doctor when you know that you're going to have to deal with it on your own. So if you have someone, a child with very bad meningitis, or you've got someone who comes in with a gunshot, unfortunately, you're just going to have to work it out and deal with it as best you can. And so that really does create quite a different mindset. As in my case, I had no operating theatre. How do you build an operating theatre? How do you get theatre lights? What is it like to do an operation when you have to do the anaesthetic and the surgery at the same time? These sorts of teaching materials really helped us, but they're not the kind of thing, obviously, that would normally be taught in a standard surgical program. So the third part was we had to find a way to support our doctors. We had to create a society. We had to find ways to get these doctors out of these remote places, get them some rest, get them some fellowship, get them some teaching. Very often they're on their own. You can imagine how exhausting it is to have responsibility for 100,000 people if you're the only doctor there. So the society was formed in 2009, and that not only helped to support these doctors, but also became the main tool of advocacy in the country for matters to do with rural health. Which brings us to the last thing. We teach our doctors things like public speaking, how to debate. These are actually parts of the training program, because we know that they are going to be the mouthpiece for their community and for bending the health system to where they think it really needs to go. They've got to be able to articulate in public, the issues as they see them. And so we actually spend a bit of time on actually inputting to them. How do you stand up in public? How do you craft a speech? These sorts of things, which again are perhaps not part of a standard general practice training program, but have been very valuable to us. Rebecca, who's the doctor on the right, wrote a book. I think she's the only doctor in PNG that has. It's a good read. Stories of, I should say that the term last doctor, which was the name of this talk, in Melanesian Pidgin, the idea of the last place means it's the place that's the furthest away, the most forgotten. So these last doctors are the ones that are sort of working in these forgotten places. This is the map that it currently stands. So I'm no longer the president of the society, but the current president, he didn't like my colour scheme, so he changed it. His rationale was that he says rural doctors are people, at least he sees them as people who aren't looking for greener pastures, but people who are looking for brown pastures, and they want to turn them green. So you can see under his map that things are slowly starting to improve. We've still got a huge long way to go, but I think that that phrase is one that kind of sticks and has really caught on amongst our cohort of doctors. So in closing, just a few little lessons, I suppose, from my point of view. Don't let the perfect become the enemy of the good. That's been a massive one for us. Medical standards have their role, but they can actually be counterproductive, if they actually get in the way of the overall goal. You've got to keep your eye on the ball as to what you're trying to achieve in the overall, needs of the community. The idea is to serve the community, not to serve the standards. And so that can be quite an interesting balance. Secondly, you've got to think flexibly. I mean, we have to be incredibly flexible. Obviously, if you're a lone doctor, you cannot do things the way that you were necessarily taught to do them, perhaps in Australia. If your bridge falls down and it's your only contact, you've got to find a way around it, whether that means getting the community together to build a new road, or you don't have an orthopaedic bed, you might have to try and make one. You might have to teach a nurse how to give anaesthetics or even to do surgery. These are unorthodox things and yet incredibly necessary to your sort of mindset when you work in a place like this. Look, for me, I've got to say this has been a huge lesson. You've got to be humble enough to accept your ignorance and also your failures if you're going to progress. These are just my own personal, I suppose, reflections. Sometimes fear and shame prevent us from having the courage to try things, admitting that I just don't know. Make it hard for us to ask for help, and they also make it difficult to us to learn from the inevitable failures. We will all fail in clinical scenarios and in life, but you can learn from them. This is a guy who had an airway obstruction. It was the first time I ever had to do a tracheostomy. I'd never seen one before. You've got to have the courage to try things, and I think there is a real relevance for this in South Australia, having worked down in Narracourt. I do get the sense that perhaps we have the choice to either increasingly retreat on the front of the things that we're willing to try and refer more, or we can try more and refer less. Now, obviously, there's a balance. You guys will have to find that balance, but I think clinical courage is a huge topic that we really do need to talk more about. admitting that you don't know. You know, the first time I had a guy that his brains were dripping on the floor from an axe wound, you know, I have no idea what to do here, and I've got to ring someone and say, I don't know what to do. What can, you know, any ideas? It's a really difficult conversation just to say, I'm clueless. But, you know, that can open the door to learning from failures. I won't tell you this guy's full story. It was an attempted decapitation. He survived it, was quadriplegic, and I made a whole heap of mistakes along the way. But you can learn from your mistakes, which brings me to my second favourite book of all time, which is Murtaugh's Cautionary Tales, which I think is just an absolute must-read for any of you young doctors that haven't read it yet. Such a humble book about all his mistakes and failures. And the thesis of the book, of course, is that everyone will make mistakes, but you can learn from them so that you don't make the same mistake twice. Think outward, keep thinking outward. You know, that's obviously we're here for our communities. The temptation is always to go inward, but I'd encourage you, keep thinking outward. That's how we will be the best help to our communities around us. And lastly, just push on. You know, nothing in life gets done overnight. Have a goal, have a strategy, but be prepared to work for it. Be prepared to summer and winter. You'll have seasons where you're winning, you'll have seasons where you get setbacks, but push on because no lasting change happens overnight. And I think I'm slightly over time, but I think that's it, Paul.
Thank you, David. A profound set of wisdom there. And I invite questions from people. My initial question would be, to what extent do you think that people who are prepared, say, with the ACRAM RG curriculum or the RACGP Rural Generalist curriculum, do they have something to offer in Papua New Guinea, or is it totally irrelevant?
No, it's not irrelevant, but I would say, you know, when you ask that question, I'm immediately thinking in circles. I think there are places where you can go up and you can give. It's a different culture, and it takes time to learn a new culture, and you don't usually do that in 2 or 3 weeks. So, you know, it helps if you can go for longer. But I think also, Paul, I've really wrestled with how can PNG be a benefit to your people? You know, there are all sorts of opportunities, I think, in PNG for example, people who want to learn how to do a cesarean, or there may be all sorts of skills. I mean, you know, many district hospitals are delivering 3,000, 4,000, 5,000 babies a year, and they might have 2 doctors. So there are opportunities, and if we can find a way to convince our colleges that it's actually in our interest to partner with PNG, I think there are actually opportunities in both directions. That's a big discussion, but I'd love to see that agenda advanced.
Well, that's certainly something we can progress together. Sharon.
Thanks, Dr. Mills. That was fascinating. Really interested in your insights and advice, I guess, around well-being for yourself and other medical staff or health staff in general, especially in light of that solo practice and innovation you had to, and the lack of resources. I guess even in compassion fatigue element, how did you manage that?
Well, I mean, there's a lot in that question. Let's just talk about the fatigue, I suppose. I had to become completely okay with walking away, which is not easy when there are no locums, there's no one to replace you. I had to become accepting of the fact that there had been nothing before I was there, and there will be nothing when, in terms of medical support. Of course, there are nurses and other care, but there's no medical care when I wasn't going to be there, and I just had to accept that. Very much seeing it as a marathon and not a sprint, and I had to, if I was going to be there for the long term, I had to be able to walk away, catch my breath, and go back and be okay with that. It's not easy because you know that there are going to be people who suffer when you're not there, but you know, for the long-term goal, I had to be okay with just walking away. In terms of the compassion fatigue, that's a much more difficult question, so perhaps I won't tackle it for the sake of time, but at least I've done part of the question.
Sure, thanks, and fantastic work. Well done.
Thanks, David. James.
Yeah, thanks for the talk, David. We very, very briefly crossed paths, but I think I was either an intern or a medical student and you were visiting Berry. And one thing I remembered was you telling everyone in theatre to stop throwing stuff away, and we had a big bin catching all of the equipment you could just rinse and reuse, because I think at that stage you were telling me you had to rinse and reuse your gloves and just about everything. Did you ever, well, that was, first of all, was eye-opening to see how much medical waste we have. But also, did you ever work out some sort of way to get all that back to PNG or anything like that? Because I think you were working that on the time, but that was about 15, 16 years ago or something like
that. Yeah, my suitcases, just last week I came with, every time I do an anaesthetic list now in Naracoorte, I just save my masks, save any hats I wear and just stick them in, because, they're the sorts of small things. And who taught me that? It wasn't actually PNG that taught me that. It was my GP trainer in the Northern Territory, who came to visit me once, and he saw me change a dressing on one of my practice patients. I took the patient's bandage off and immediately threw it in the bin. And, he stopped me and said, look, just think about that, what you've just done. That bandage can be rewashed and given to the patient who has to, and so it was the first time I'd really been challenged on the fact that, it's a bit of a throwaway culture. So, I'm sure there are administrators who are paid to do the maths on this stuff and they have reasons for doing it, but at the same time, Compium was half built on things that were thrown out of Australia, to be honest.
Hamish.
Yeah, thank you very much. It sort of brings back memory. I went to PNG as a 6th-year medical student with Chris Acott and AusAid with the Max Faxon EMT team, and had to deal with lots of machete wounds and things. People would walk 3 days to get there. So, yeah, definitely some memories, good and bad, because I think there was cannibals and Highland elections and people getting superpowers from eating appendages at the time, which definitely made my parents reconsider pulling me off the plane at that point in time. But I sort of found that the experience was amazing to be able to do it. And I had some really good teaching there, especially as a 6th-year student, doing a lot of the airways and bag masking and getting a lot of time with a lot of consultants that are given their time up to be there. And I think the skills pre-internship probably got me ship shape a lot quicker than I would have otherwise. And as I guess the director of training for the race program, it sort of, I got the same sort of thought as Paul as to, is there a way to sort of do it in a way that actually evaluates to the trainees and what can be offered, because the upskilling potential is massive in that environment with the teaching.
Yeah, I mean, I'll just briefly speak to part of that, which is the issue about people being worried to go there. Look, every place has its difficulties. I'm not going to cover up the fact that PNG has its, but the fears are greatly exaggerated. The closer you get to it, the smaller they appear in reality. And I would not discourage anyone from coming to PNG to get some clinical experience, as long as you're prepared to sort of bend with things. I think there's enormous scope for, basically, my discussions with both colleges faltered on the fact that they were worried about the insurance issue. And this is where I think, the clinical courage part of it is a real relevant thing. I think, we need to be proactive on this and say that we're probably losing more than we're gaining when we have that kind of attitude. So, it's a big question, but I would always encourage people to visit. It's an amazing place, amazing.
Agreed. I think the experience, I was in Moresby and Alatau and polar sort of experiences between the two sites, but as I said, highly valuable in every way. So when I came back for that, with a lot more understanding about PNG from the brief time, but experience-wise was absolutely amazing, even that sort of brief couple of weeks.
Yep.
Well, thank you, everyone. We'll make an end to today's session there. I think it's a start, though, in terms of further collaboration. I think a lot of us have heard the opportunities for us to learn from the work that you're doing and from the opportunities that there are in PNG, and to do that in a respectful way that means that PNG may get some benefit from that learning. So certainly with the advent of the 4-year medical program now in the Riverland and the 5-year postgraduate medical program in the Riverland, we really don't have any excuse to not explore all the opportunities there are to work more closely with our closest neighbour. We often think about going to places much further away, but it's actually only a short boat ride from the top of Australia, and you're there. So thank you very much. Thank you for sharing what it means to be a doctor, what it means to be a person in another culture, and what it means to be a human anywhere in the world, and the way you've learnt that in PNG and shared that with us. So thank you to everyone for being part of this week's race Grand Round, and I will be welcoming you back in the very near future. Nakan, Ananingdi, and we'll see you later.